My
yes,
second
has a speak,
presentation is a lecture, the role of echocardiography in the IHD. So it's a huge topics to cover within the 14 minutes. But I'll try to summarize the thing within 14 minutes, I can assure you. The most important thing is that the European guidelines is that acute coronary syndrome. The role of echocardiography, it is depicted. Please read this in your textbook. It is already come. And where is the importance of the echocardiography in acute coronary syndrome? Whether it is a non-STEMI, whether it is a STEMI, whether it is a IHD, whether it is a chest pain, whether it is an emergency, echocardiography is in. Why? Because see, if you see the ischemic cascade, the first thing to occur is at the microvascular level. We don't have practically any echocardiographic modalities to detect this. The only modalities coming is the computerized coronary tomography angiography, CCTA, where you can see the vasculatures of the cardiac vasculatures, but that is still in experimental stage. And now coming the coronary flow reserve, which is altered. And this coronary flow reserve can only be done by the myocardial perfusion studies, no other things. If you do the myocardial perfusion by contrast echocardiography, you can have some idea about the myocardial. With the stress, you can have the coronary myocardial flow reserve. And next is the myocardial perfusion imaging. Of course, we do detect by the coronary perfusion imaging. I'll show one example at the end, near the end, how we can detect the coronary perfusion imaging by contrast echocardiography. And next, you can do the diastolic dysfunction. That we have a lot of modalities now. And next is the systolic dysfunction by dobutamine stress echocardiography. And last is the stress test, or what we call the TMT, treadmill test. So the sequence of event in the ACAC is, first is the normal ventricular function. Second is the perfusion abnormalities, which is detected with the myocardial contrast echocardiography with perfusion studies. Next comes the abnormal long axis function that we can do with the strain imaging. And last is the regional wall motion abnormality. And of course, the last is the ECG changes we can detect with the TMT or the stress test. And this stable, whereas in the stable ischemic disease, where the most important is the stress echocardiography. You can detect the stress coronary flow reserve by the stress echocardiography. You can detect the ischemia by stress echocardiography, and you can detect the viability, which is already explained by Dr. Samir Srivastav in the morning. So this is the actually summarization of the finding with what 2D echo and the stress echo can do it. I can give you few examples what the IHD echo can give you in the IHD. First is the acute myocardial infarction. See, this is a case of the acute anterior wall myocardial infarction. Even after the reperfusion, within 1 hour, you can see absolutely normal contractility. And that same thing in the inferior wall, you can send the acute inferior wall myocardial infarction. And again, after reperfusion, you can, within a few hours, you can find out absolutely normal contraction of both the inferior walls. Not only the wall motion abnormalities, it can detect all the complication of the ischemic heart disease enumerated here. And I can show you one by one. This is a case of acute mitral regurgitation because of the papillary muscle rupture after the myocardial infarction. Very important finding, I'll say you. See, there are the two images here. Is a myocard, there is a MR is there. See, this patient is the acute myocardial regurgitation. Why? Why? Because of three important points. First point, see the LA. LA normal, size is normal, volume is normal. Compared to the here, LA is enlarged. Second thing, to see the LV contractility. LV contractility is a hypercontractile in a case of acute mitral regurgitation. In contrast to the chronic mitral regurgitation, it is rather hypocontractile or even normal contractility. Then you can detect the pseudoaneurysm in a case of any myocardial infarction. Not only that, you can determine the ventricular septal rupture, that you can determine very easily with your echocardiography. And that same thing, another patient, the ventricular septal rupture. Is another case of ventricular septal rupture where the apical part of the septum is totally sloughed out, and the apical part of the LV incorporated into the apical part of the RV, absolutely totally ruptures. Total ruptures. And you can see the only is restricted by the moderator band of the RV. So it's a huge ventricular septal rupture. Then you can detect the after myocardial infarction, any intercardiac thrombus. It could be a stable big thrombus or it could be a grape-like thrombus. Not only that, in addition to, you can determine the RV infarcted, where you can see the RV free wall is totally akinetic with very TR is a moderate TR, but is a low flow TR. And you can see this is a moderate TR. Not only that, you can detect even the what Dr. Samir has said, the completely free wall rupture. And this is the same story. These patients only give this image only to die after 20 minutes. So I'll give two cases for this, enumerating all these things. Here is a case of 58-year male. Is the anterior wall MI 2 years back, treated by thrombolysis, PCI to the LAD, asymptomatic for 1 year, but he again developed angina for 1 year and performed on anti-anginal therapy with the nitrates and diltiazem. So what happens in this patient? You can see there is a absolutely thinned out and akinetic ventricular septum, but other walls, we do not know what is the viability status. So this is the resting sacs. This is the resting fourth chamber view. And when you do the stress dobutamine echo, this is the low dose echo, you can see there is a definite increase in the inferior wall contractility, increase of the inferior posterior wall. And you can see the contractility in the inferior posterior wall. And same thing with the low dose, you can see the contractility is increased with the low dose of the inferior posterior wall, whereas the anterior wall and the septal, apical septal wall there is no change and no change. But when it's go to the high dose, you can see again, this is deteriorated, inferior posterior wall is deteriorated. High dose is again, inferior posterior wall is totally deteriorated. So what we got is a fixed defect in the anteroseptal wall, whereas a biphasic response of the inferior posterior wall. And there is initial improvement at low doses with subsequent worsening of the myocardial function at the higher dobutamine dose. And if you do we have done the angiography, there is a tight arteriostenosis. And another one case also for imaging the perfusion studies, you can say 45-year man, known diabetic and hypertensive on irregular medication, acute chest pain for the last 2 hours, doubtful unequivocal ECG, cardiac enzymes yet to rise. There is some RWA in the anteroseptal wall presented with the emergency room. So this ECG is unequivocal. There is some suggestion is there, but if you do you can see there's some abnormality in the apical septum. There may be some hypokinesia is there, but if you do the perfusion studies, look at the perfusion studies, you could see after flushing, look at the after flushing, what happened after flushing. You'll find there is a after flushing, the immediate appearance of the infraposterior wall, but the anterior wall is absolutely coming, the contrast is coming, but after 10, 12, 15, 20 beats. So there is then rate, there is a definitely flow limiting stenosis. And if in the slow motion, you can appreciate this after flushing. See, this is there. Very contrast is coming, but very slow speed. It should come within 2 to 3 beats. But if it is coming beyond 5 or 6 beats, that means there is a contrast is coming. Viable myocardium is still viable, but there is a flow limiting stenosis. And you can see the angiography, this is the LAD stenosis. So how do we interpret? This is an again slide taken from Dr. Roxas Senior. See, if you get a wall motion study normal, myocardial contrast normal, then your diagnostic confidence is very high that we are dealing with the normal part. If your wall motion is abnormal, myocardial contraction is abnormal, that means you are dealing with the flow limiting CAD. If your wall is abnormal, but myocardial contrast is normal, then of course we are dealing with the stunning and hibernating myocardium. Then you have to wait it. Then if you get a wall motion is normal, but myocardial contrast is abnormal, then you should consider this an artifact. And similarly, in the stress echo, If your wall motion is now normal, myocardial contrast is normal, then diagnostic confidence is again high. If your new wall motion abnormality and the perfusion defect, then high perfusion defect often depicts extent of ischemia better. If you have a new wall motion abnormality, but myocardial contrast is normal, again consider the artifact. And finally, if you have a normal wall motion and myocardial perfusion defect, probably would be ischemia. So my last slide is that MCE without stress echo is a promising technique for assessment of early myocardial ischemia at resting and also in stress. So a combination of the myocardial contrast imaging and WMA wall motion abnormality provided very high sensitivity and specificity for detection of coronary artery disease. Thank you.